Hello, it's my honor to be here today. I thank you for inviting me to present this topic on the role of antimetabolites in biologics in non-infectious uveitis. So this is a bit of a lecture, so bear with me. I have no relevant financial disclosures or conflicts of interest to disclose. So broadly, we know that if we classify uveitis, it's basically infectious, non-infectious as masquerade. I will not go into the diagnostics of it now. Basically, we will talk about the management of non-infectious uveitis. So in this region, we tend to use immunosuppressives a lot more. So first of all, we need to speak about steroids, because in any case of non-infectious uveitis, steroids are the unavoidable first line, whether it be topical, periocular, or systemic, depending on whether it's anterior, posterior, or pars planitis. So as of now, it's the only agent that achieves rapid control of symptoms. So steroids are not something we'll eliminate in the near future. However, in chronic recurrent uveitis, we all know that steroids can cause glaucoma and cataract, and systemic use adds another whole lot of complications, including but not limited to weight gain, mental depression, mood changes, and a whole lot more. So nowadays, previously, the main focus is to get the patients off the topical and systemic steroids as fast as possible in chronic diseases. For example, in uveitis, that lasts more than 3 months. So the recent concept with biologics is that they are immunomodulators. So there is a chance of cure. So the process can the theory is that it can technically possibly be reversed. So when do we use uveitis? When we use antimetabolites and biologics. So the important thing is there are some primary indications which I'll look in a moment. But the important thing is sight-threatening bilateral uveitis, where the patient has an intolerance to corticosteroids, where he has excessive side effects, and so on and so forth. And these are some of the indications that we use: Vogt gonoriaty, Harada, sympathetic ophthalmia, Behçet, serpiginous, which is obviously we have to exclude tuberculosis, GI-associated uveitis, pars planitis. Notice we don't have birdshot because it's not really common in this region. It's more of a Western thing, but that's also an important indication of antimetabolites and biologics. So broadly, I have divided them into 4 types: antimetabolites, inhibitors of T cell signaling, alkylating agents, and biologics. The first 3, they are actually immunosuppressives. That is, they suppress the immune system. And the last ones, the biologics, they are the immunomodulators, that they alter the immune system so that we can change the response. So these are agents that we pretty commonly use. Azathioprine was the original agent. It inhibits DNA replication and RNA transcription, but it has a higher risk ratio of bone marrow suppression. So it has largely been supplanted by mycophenolate, but in this region we still use azathioprine quite a lot because of the cost associations. So mycophenolate costs almost twice as much as azathioprine. So despite the increased risk of side effects, we still tend to use azathioprine a lot in this region. And methotrexate inhibits DNA replication. So it's excellent to use in children, but it can actually basically be used in any form of infectious uveitis. So calcineurin inhibitors, these include cyclosporin and tacrolimus. These are not commonly used as first agents. These are commonly added as a second agents or first agents when other agents are ineffective. Cyclosporin is used in a dose of 2 to 7 milligrams per kg body weight, and so on and so forth. Alkylating agents such as cyclophosphamide and chlorambucil, they alkylate purines in DNA and RNA. So cyclophosphomides have they have very high adverse effect ratio, so they are commonly actually not very commonly used as first line. The only indication is necrotizing scleritis, which is associated with Wegener's and relapsing polychondritis, and chlorambucil is really not used a whole lot. So as you can see, there's a whole lot of biologics that we can use. So TNF alpha inhibitors, B cell inhibitors, interferon, the whole list goes on. But actually the agents that have been researched the most are the TNF alpha inhibitors. So we can broadly, the infliximab has been used, it's one of the older agents. So infliximab, adalimumab, and etanercept, these are known as the first generation TNF alpha inhibitors. And golimumab and certolizumab, these are the newer agents, but these have not been tested as much in uveitis. So adalimumab, of this long list of agents, adalimumab remains the only agent that has actually been extensively researched for the sole treatment of uveitis. and in fact it's the only treatment that's FDA approved for uveitis. So how to use? I'll just go very briefly through this. Mycophenolate, we commonly use it in dosages of 1 to 3 grams daily, and azathioprine, it's usually used at a dose of 100 to 150 milligrams daily. Onset of action usually takes 4 to 6 weeks, and they require blood count monitoring every 4 weeks, and it's also prudent to do a liver hepatic function every 3 months in case of azathioprine. So the main clinical adverse effect that we know is bone marrow suppression, but it can also cause hepatotoxicity. Methotrexate actually is, both mycophenolate and methotrexate are actually quite well tolerated in children, but methotrexate is preferred, and it's actually the first agent that's preferred in juvenile GI-associated arthritis. It's usually oral, but it can also be given intravenously if you want a higher additive effect. So what we do is we give 10 milligrams for the first month just to screen out any side effects, and then it can be increased up to a maximum of 25 milligrams, and it's actually very well tolerated in children. And since it's a folinic acid inhibitor, dihydrofolate reductase inhibitor, we must have folic acid cover, and it requires monthly monitoring of blood counts and liver function tests. As I already said, it works well in GI-associated arthritis and scleritis, but it can be used in almost any type of ocular inflammation. Other specific indications include panuveitis, birdshot, VKH, and sympathetic ophthalmia. It can also be conversely used to improve control of uveitic CME when steroids don't appear to have enough of an effect. And the end point of treatment is actually a bit of a debate, because but it's usually continued between 6 to 24 months, and a lot of practitioners actually say that continuing antimetabolites for at least 2 years gives a better chance of remission. So I want to talk about biologics, mainly adalimumab in this case, because it's given as a subcutaneous injection, so it's comparatively easier to give than the other biologics, most of which have to be given as infusions. And its dose is age dependent. In adults, we commonly give 80 milligram loading dose, followed by 40 milligrams every 2 weeks. So depending on the response, it can actually be given every week, and the dose is titrated with the response. If you gain adequate control, the intervals are actually gradually increased, and when we can increase the interval up to 3 months, that is 12 weeks, without getting a relapse of uveitis, we can attempt to wean the patient of that drug. And it's sometimes used with low-dose methotrexate at a dose of 10 milligrams, so as to prevent resistance. So adalimumab is actually one of the first biologics trials for use in uveitis. I don't think there are any large-scale studies that have researched other biologics. So Visual 1 and Visual 2 were the prototype studies. Visual 1 actually recruited patients with active uveitis, whereas Visual 2 recruited patients with inactive uveitis. And the patients who completed Visual 1 and Visual 2, a subset of them were continued onto Visual 3, and it was meant to reflect real-world data. So what was found that Visual 1 and 2 established the efficacy. So it was seen that so in Visual 1 and 2, the patients were given a steroids at the tapering dose for 6 weeks, and then it was stopped, and the time to treatment failure was basically measured. So what was seen that in Visual 1, 60% of patients achieved control, but what this also points out is that 40% of patients didn't. So as of now, there is no treatment that is 100% effective in uveitis. And Visual 2 assessed the same. So since the patients were already inactive, a higher proportion, 83% of patients achieved quiescence. And Visual 3, as I said, it's meant to represent real-world data. So they had better outcomes in the patients with active uveitis. 66% of those maintained their vision. And the reason for this could be that as compared to Visual 1 and 2, in Visual 3, the investigators were allowed to add steroids as needed for acute exacerbations. And most patients with inactive uveitis, that is 78% of patients actually maintained the vision with adalimumab, and 93% of those were without steroids. So they were able to be safely off steroids for a period of time, and no new safety signals were identified. I won't speak to, I don't have many, so the problem with this region is that biologics are actually very expensive. So adalimumab, we have a generic available, so that's actually the only one that we tend to use.
I think
and that's the only one that's available. The other ones,
Mohd.
they have no large-scale studies to support their
Dr.
use,
Mohd.
but they are used as second-line agents. Oh,
Time is up.
oh, sorry, extremely sorry. So I'll just quickly go through this. So considering our region, the main limitation is cost and availability, and they have to be prescribed in collaboration with a rheumatologist or internist. And future trends will probably lean towards biologics as the costs come down. But in this case, it's essential. Three things are essential. We have to exclude tuberculosis as a cause prior to the initiation of biologics. We have to counsel the patients, and they have to be motivated for the long-term follow-up that is required. And we have to maintain close collaboration with an internist. So, as I said, no treatment is without side effects. No treatment is 100% effective. There are a wide variety of agents to choose from. It is not for me to say that this agent is superior than others. All of them have a place in the treatment of uveitis. And we must exclude, particularly in this region, we must exclude tuberculosis prior to the initiation. Thank you for your attention.